بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد عليه أفضل الصلاة وأزكى التسليم. Dr. Muhammad, can you see my slide?
Very clear. Thank you.
Thank you so much. So really, it's my great pleasure to be part of this scientific meeting, and I would like to thank the organizer and in particular Dr. Nagwa Ibrahim. I have been tasked over the next 20 minutes or so to discuss with you the role of immunotherapy in a patient with triple negative breast cancer. So as you know that the whole interest in looking at immunotherapy and breast cancer has an interesting history, because breast cancer is not very immunogenic, but it was discovered within the last decade that there is a lymphocytic infiltrate. And because we were able to differentiate CD8 from CD4 cells, there was an understanding that a tumor that had more infiltration of lymphocytes that were CD8 or cytotoxic T lymphocyte were actually associated with a better outcome. These cells are now called TILs, or tumor infiltrating lymphocyte, and there is actually a website that can teach us how to enumerate TILs in a particular
دكتور متعب، أنا آسف بس على مقاطعة حضرتك، بس الصوت مش واضح شوية. الصوت زي في خرفشة كده. مش عارف دي مشكلة مايك.
والله أنا ما حطيت مايك.
هو ممكن حضرتك تعلي صوتك شوية بس، لأن الصوت الواطي بيبقى فيه خرفشة شوية. لما حضرتك عليت صوتك سنة بقى واضح. عشان
كده كويس؟ كده كويس؟ كده لما أتكلم. طيب. And this actually gave us a little bit of window on the idea that the host immune response against cancer was actually very important for that cancer outcome. And this is actually true for renal cell carcinoma, melanoma, and lung cancer. The subtypes of triple negative breast cancer and HER2 positive breast cancer are associated with more TILs. And if we have TILs, then we will have a better chance of complete pathological response, disease-free survival, overall survival in early setting, and longer PFS in metastatic setting. So the checkpoint inhibitor monotherapy was the start for investigating immunotherapy in breast cancer. Single agent Pembrolizumab was tested in patients with triple negative breast cancer and in patients with hormone receptor positive disease, while single agent Atezolizumab was tested in patients with triple negative breast cancer, and the response rate for Pembro and Atezo was 18.5 and 19% respectively. We thought that was very exciting, because when we did a larger expanded trial, unfortunately, the results were disappointing, and the response rate was down to 6% in patients who were treated in the second or greater line setting. So the investigator then focused on PD-L1 positive tumor, and they showed that patients who were treated in the first line setting had a response rate of 20 to 25%. So the single agent Durvalumab, which you can see at the bottom of this slide, was associated with a very low response rate and in all different subtypes of breast cancer. This is actually very interesting publication where the investigator looked at matched sample from the primary to the metastatic setting, and what they were able to show that not only the percentage of the TILs count go down in the metastatic site compared with the primary, but also the PD-L1 expression goes down. So as the tumor start to progress, we start to lose that window to utilize the host immune response to treat cancer. So why does it matter when we see a response rate like 19 or 20%? Because those patients who actually responded, they had a remarkable overall survival, even in patients who are heavily pretreated. So as you know, patient with metastatic triple negative breast cancer has a poor outcome, and we are so limited in our ability to treat their cancer. This is the cancer immunity cycle where we can actually intervene at different points to augment the immune response. Although not developed as immunotherapy, the chemotherapy can primarily promote cycle step 1, which is the release of cancer cell antigen. And in patients who received chemotherapy at a neoadjuvant setting and had defective cell killing, we observed at the end more of this lymphocytic infiltrate, the cytotoxic T cells, meaning that chemotherapy can enhance the host immune response. The easiest way to enhance the immune response is to give chemotherapy, to give radiation treatment, or a targeted therapy. The CARs, which are the chimeric antigen receptor, is not yet successful in breast cancer. This is the IMpassion 130, and because we give chemotherapy for metastatic triple negative breast cancer, and it does not seem to be going away. And if we could enhance the immune response with chemotherapy, then we would make a big difference. And the IMpassion 130, which included metastatic triple negative breast cancer with no prior therapy for advanced disease, the patient had to be more than 1 year from their adjuvant or a neoadjuvant taxane chemotherapy, because the investigator were worried about the control arm performance. The stratification factors are listed and included prior taxane use versus not, liver metastasis versus not, and PD-L1 status on the immune cells, which was defined as positive 1% or more versus negative. And the patients were randomized in 1-to-1 to receive atezolizumab at 840 milligram IV on days 115 of 28 days cycle, and nab-paclitaxel at 100 milligram per meter square IV on days 1, 8, and 15 of 28 days cycle versus a placebo IV and nab-paclitaxel. And the primary endpoint, as you can see, was a co-endpoint of PFS and overall survival in intent to treat population and in PD-L1 positive population. And the result, as you know, only the population with PD-L1 positive disease benefits. So the PD-L1 positivity was the only in the immune cells, meaning that the host immune response that is positive for PD-L1 status. Very few tumor cells were positive for PD-L1, and adding atezolizumab did not make a difference. The SP142 assay was the diagnostic assay used, and the combination of atezo and nab-paclitaxel was associated with modest benefit of 2.2 month benefit in PFS in PD-L1 positive population, but was associated with impressive 7-month absolute difference in the overall survival in PD-L1 positive population. So why this is an impressive result? This is the first trial to show overall survival benefit in metastatic triple negative breast cancer, and obviously, we want our patient to live longer. And the second, when we look at the placebo arm, which is the control arm, regardless of the PD-L1 status, the median overall survival was 1.5 years. So keep in mind that those patients are the best of the best. Those patients are the patients that are 1 year out or more from adjuvant taxane or had de novo metastatic disease that we think as a more sensitive disease. And on the other hand, patients within 1 year of their adjuvant or a neoadjuvant treatment, their median overall survival is barely 1 year. And also that the checkpoint inhibitor are generally well tolerated. We do see a rash and other immune-related toxicity like pneumonitis and hypothyroidism, hyperthyroidism, hepatitis, adrenal insufficiency, and colitis. And these are the most clinically important toxicity. And thankfully, they are of very few low percentage, but most of this toxicity other than rash, pneumonitis, hepatitis do not go away. So if you have a patient with hypothyroidism or adrenal insufficiency, then this patient will need hormone replacement treatment for the rest of their life. What about the PD-L1 status in primary versus metastatic tissue? The previous data has suggested that some metastatic sites have less PD-L1 expression. For example, tumor that metastasize to the liver have a worse prognosis and a lower PD-L1 positivity and less tumor infiltrating lymphocyte. So to examine whether it make a difference where we check the PD-L1 status on the primary tumor tissue in the breast or metastatic site, the investigator looked at PD-L1 efficacy in primary versus metastatic, and both seems to be pretty good and both predicted atezolizumab benefit in overall survival. But we need to keep in mind that the median time of sample collection to randomization was only 2 years, but were obtained within 2 months of randomization. When the investigator looked at PD-L1 status at the anatomical location of the tumor, 5% only sample came from the liver and was positive for PD-L1 only in 13%. So what about the different assay compared to the 22C3 and SB263? The SB142 is less sensitive, meaning that patients have positive PD-L1 status using the SB142. And looking at the overall lab between this assay, the SB142 was included within these different assays. So what we can conclude is the SB142 is probably our best test to predict outcome. What about the Keynote 119? So this is a phase 3 Pembrolizumab. There's a chemotherapy in the second and third line setting of metastatic triple-negative breast cancer, and patient with metastatic triple breast cancer with 1 or 2 prior systemic treatment in the advanced setting were randomized in 1-to-1 fashion to receive either single agent Pembro versus treatment of physician choice, either capecitabine, eribulin, gemcitabine, or phenylephrine. And the primary endpoint were overall survival in patients with PD-L1 combined positive score of 10 or more, and in patients with PD-L1 positive 1 or more, and in all patients. And as you can see, from the overall survival, the Pembro did not improve the overall significantly in patient with CPS score 10 or more, or CPS score of 1 or more, or in all patients. So the Sapphire 02 is a phase 2 trial where the investigator looked at maintenance Durvalumab following chemotherapy induction. And as you can see, the HER2-negative metastatic breast cancer, triple-negative or ER-positive HER2-negative were treated with 6 to 8 cycles of chemotherapy. Then the NGS was done, and patients who had mutation were randomized to a targeted agent, while patients who did not have a mutation were randomized into 2-to-1 to either a single agent Durvalumab or maintenance chemotherapy. You can see that 90% of the patients were randomized after first line of chemotherapy, and approximately 1/3 of the patient had triple negative, and 60% of the patient had ER positive disease, and 1/3 of the patient had PD-L1 positive by the SP142, and there was actually no difference in the overall survival in the overall population, but in patients with triple negative breast cancer, the median overall survival improved from 14 months with chemotherapy to 21 months with Durvalumab. And also in patients with PD-L1 positive breast cancer, their median overall survival improved from 12 months with chemo to 26 months with Durvalumab, suggesting an overall survival benefit. So this study generates the hypothesis that single agent Durvalumab in the metastatic setting could improve the outcome in metastatic triple negative breast cancer as a maintenance treatment. What about this clinical trial, which actually was approved last night, like in 12 hours ago by the FDA? So the Keynote 355 was presented at the ASCO virtual meeting and tested the addition of Pembro to treatment of physician choice of chemotherapy, either with weekly nab-paclitaxel, or Carbogen. And these were patients that had metastatic first-line triple-negative breast cancer, and they were randomized into 2-1 fashion. And the PFS was tested using the hierarchical strategy. Combined positive score of at least 10 was tested first, then combined positive score of 1, and then the in the patient intent to treat population only if previous analysis were positive. And as you can see in the far right, the PFS was actually significantly improved with a hazard ratio of 0.65 among patients who had PD-L1 CPS score of at least 10 or above. And in the middle, the combined positive score of at least 1 was tested, and the p-value of 0.0014 did not meet the pre-specified p-value of 0.0011. And because of this, it was not tested in the intent to treat population. As you can see, although there was a trend in the intent to treat population and the CPS 1 and above population, the only statistical significant benefit came for the population with CPS of at least 10, with PFS of 5.6 months versus 9.7 a month with the addition of Pembro, and only 38% of the patient in the Keynote 355 had a CPS score of at least 10%. So what about the immune-mediated adverse event with Pembro? There is a cost always to pay for everything we do, other than the financial cost when we are adding a targeted agent to chemotherapy cost for toxicity. And we see that the rate of the immune-related adverse event clearly being higher with the addition of Pembro in the Keynote 355, about 15% incidence of hypothyroidism and 5% hyperthyroidism, and approximately 2% for both pneumonitis and colitis. So some of these adverse events are irreversible. So I did a comparison of the IMpassion 130 and Keynote 355 outcome for the first line setting. So you can see that the PFS and the hazard ratio in the intent to treat population in the IMpassion 130 improved from 5.5 to 7.2 months with a hazard ratio of 0.80, and in the Keynote the PFS improved from 5.6 to 7.5 months with a hazard ratio of 0.82. And when we look at the PD-L1 positive subset, we can see that there was 41% positive PD-L1 in the IMpassion on the immune cells versus 38% with CPS score of 10% or more, and the PFS improved from 5 to 7.5 months in the IMpassion and from 5.6 to 9.7 months in the Keynote with a hazard ratio of 0.62 versus 0.65. The overall survival was reported in the IMpassion 130 and was not reported yet in the Keynote, and both were approved. And as I mentioned earlier, the Keynote was approved last night by the US FDA. What about the I-SPY2? And just I think because I have a limited time, so I will skip this clinical trial of Gibar Nuevo, and I will come to the Keynote 522, which actually tested in the early disease. So this is a phase 3 where 600 patients with a newly diagnosed triple negative breast cancer, they have to be node positive disease T2 or greater, and were randomized to receive Pembro versus chemotherapy. And actually this was associated with improvement in pathological complete response, and there was actually impressive improvement in patient with lymph node positive disease. So we don't have yet event-free survival in this clinical trial, and we are waiting for that. There is another clinical trial called Nutrib, which unfortunately was not significant, but they did not use the anthracycline chemotherapy in the neoadjuvant setting. And I will just conclude with my conclusion. So the immunotherapy actually is coming of age in breast cancer, and we are going to use the combination of atezo and nab-paclitaxel in the first line metastatic triple negative, which resulted in survival benefit in a subset of patients with PD-L1 positive. The Keynote 522 also showed a high rate of complete pathological response in the neoadjuvant setting, regardless of the PD-L1 status, and the event-free survival results are awaited. And also we have now approval of Pembro in metastatic setting in triple negative breast cancer in addition with chemotherapy. The role of immunotherapy in HER2 positive and hormone receptor positive disease is actively explored. And with that, I would like to thank you for your kind attention, and I'm happy to receive your question as well as your comment. Thank you so much.